Okay, so I'm going to make a start. So welcome everybody. Thank you very much for joining. My name is Katie Blakely. I'm one of the regional programme managers within East Genomics. I work very closely with Vicky Carr, who's our lead nurse. Unfortunately, she's off sick today, so you've got me hosting this meeting. Just to cover a bit of admin, if I can find the controls to move this slide. So we are recording this session today, hopefully popping it on our website and sharing it with you all afterwards. So just be aware, please don't disclose any patient identifiable information within this meeting. And if you could also just make sure that you're not on, that your microphone's on mute. If you're not talking, that would be fantastic. If anybody does have technical issues, I've just popped my email down in the corner. If you are having problems, I'll attempt to help if you either drop me an email or through the chat. So today is one of our first monthly lunch and learn sessions that we're planning. East Genomics is involved in an exciting project around looking at cystic renal disease and particularly the nursing touch points within that pathway and developing a number of materials to support the role of genomics within that. I've got Ed joining us today, who's a renal genetics nurse specialist from South East, and Tess Harris from PKD Charity. They've both got around a 15-minute presentation each, covering some of the points there on your screen, and then we're going to have around a 10-minute Q&A session towards the end. So if you do have some questions, please save them towards the end or pop them in the chat, and we'll attempt to cover them. So I think without further ado, I will hand you over to Ed.
Morning, everyone, or rather good afternoon. Thank you again for inviting me and sharing with you about kidney genomics and how will this be impacting our patients towards their renal care pathways. So why do we test? I think this would be the second slide. Katie, I think there's an earlier slide before this.
Oh, I think I may have missed one. Sorry, Ed. Sorry. Let me just stop sharing, and what I'll do is I'll just get the right one up for you. I found you. 2 seconds. Sorry, everybody. Okay.
All right. Thank you.
Great.
So just to start, just an introduction, what is genomics? So it's basically looking into the whole genome or the complete set of the DNA. In the past, we all know that there are we thought that the only important part of the DNA is the protein coding genes, which is only comprised of roughly around 2% of the whole DNA. But as science and technology progresses, we're understanding more on the impact of the non-coding genes. So that's where we come in with genomic medicine. And of course, everyone is different, everyone is unique. It's not detrimental to have a particular gene in your DNA that would pertain to a particular condition or result to a particular condition. We're also now understanding more on the importance of epigenetics, as we say, in regards of how our behavior, our lifestyle, and other factors in place could actually help predispose to a certain condition. So with genomic medicine, with the combination and advancement of what we learn about genomics at this time, along with the information of a person's health, this would further improve their diagnosis and treatment. So we have now coined the term precision medicine, in which by utilizing these, we would be able to predict certain reactions to certain medication and other focused prevention or preventive treatments and other options. So with the NHS, the structure is quite unique. It allows equitable delivery at scale and pace for our patient benefit. And with that, NHS England and NHSI have funded the establishment of 7 genomic medicine service alliances. in which I am part of in Southeast, to enable the NHS to mainstream the power or the advantage of genomic medicine towards the population in terms of testing, in terms of any genes that they may have that could pertain to or towards precision medicine, and as part of the NHS long-term plan. Next slide, please. So why do we test for genes in the kidney? So well, at the moment, roughly 75% of children with kidney problem have an underlying genetic cause, and roughly around 1 in 10 adults that have resulted to kidney failure is still have poor testing results because it's quite limited, and as compared to in the children, it's quite more mainstream, which is led by my lead consultant Anya Koziel in Evelina. So we're trying to expand this in the adult sector as well. And of course, genetic kidney diseases are quite silent until they're in an advanced form, and once they are in the later stage or later diagnosis, it's quite restrictive on what options they may have. So there's now kidney dialysis as well as transplantation. And at the moment, conventional investigations are still non-specific in terms of ultrasound, the biopsy, and other blood tests. So we would like to incorporate genetic testing to be part of the clinical tools. And of course, the GFR and the nephron numbers of each person are quite heritable. So that would mean each patient will have their own presenting symptoms, and it's quite varied. And we all know that the kidney development is quite complex. To those that are practicing in the nephrology department, we all know that the kidney is also not only is responsible for fluid and electrolyte balance, but they're also involved in hormones and other functions such as blood pressure and so on. So understanding the genetic cause and genetic investigation is quite important towards this. Next slide. So again, there's a myriad of genetic kidney diseases, not just in renal tract malformation, glomerular development such as Alport syndrome and nephrotic syndrome, as well as other systemic genetic diseases such as Fabry's and primary oxalosis, as well as cancer syndrome such as Wilms tumor, which sometimes reflect as a cystic kidney. We actually have a patient that have been seen to have tumor in the kidneys at 6 months, which is anuric. Initial diagnosis was autosomal recessive polycystic kidney disease. However, through genetic testing, it was ruled out that this patient doesn't have polycystic kidney disease, but have shown to have WT1 gene, which is corresponding to the Wilms tumor, and have resulted to early intervention, therefore preventing future chemotherapy. So I think that's one good example in the power of genetic testing. And of course, other diseases, conditions such as calcium and phosphate sensing disorders, which could also predetermine whether or not, if the patient has hyperthyroidism because of, their diet or irresponsive to the medication they're taking. But in fact, they do have CASR gene, which affects the metabolism. Next slide. So again, why do we need for change? Well, at the moment, only 10% of adult and less than 50% of children are being offered genetic testing. It will take them multiple visits with their nephrologist before they were offered genetic testing, and we would like to improve this through the Genomics Medicine Service Alliance. So at the moment, there are more than 10% or 75% of children's kidney disease are linked to a genetic cause, and most kidney disorders would progress to kidney failure, and therefore there's now a quite limited options for them for treatment in terms of life-sustaining therapies such as dialysis and of course transplant. So we would like to improve on the prevention aspect and detecting patients that have a genetic cause so that they could have a more precise management. So again, there's a lot of barriers, pathways, and services are still disjointed in terms of incorporating this service in their toolkit, and we would like to improve on that one. Next slide. So this data that we have gathered was back in 2009, 2010 about the expenditure in the renal department nationwide. So back then it was around 1.45 billion or 1.3% of the NHS budget in terms of, dialysis therapy, their medications, and so on. I haven't seen an updated version of this because I think they're quite scared of the value or the numbers that may show. But again, with genetic testing, I think we could help in the cost effectiveness of this particular service that we're incorporating in terms of hopefully delaying or preventing of patients leading to end-stage renal disease. Next slide. Yeah, so this is just a brief pathway that we have developed in Southeast GMSA. So patients that are suspected to have a genetic kidney disease can be seen in different areas. So that could either be in the GP, in the nephrology clinic, in the secondary and tertiary, as well as patients on dialysis. So at the moment, we're focusing on patients on the nephrology clinic, in which these are patients on pre-dialysis or in regular monitoring of their kidney function. If they are shown to have cysts in the kidneys and a strong family history, we would offer them genetic testing using the National Genomics Test Directory, which involves the eligibility criteria, whether or not they can be offered genetic testing. And of course, that would depend on the method that they would need to be requested. So with that, once the extensive family history taking and medical history taken has been taken in place, consent has been received, the blood sample will be taken from the patient, and this will be sent through their corresponding genomics laboratory hub. In Southeast, we have in Guy's, and Cambridge, I believe they have their own as well. So at the moment, we were advised that whole genome sequence may take at least 6 months for a result to be ready. This can be improved, but again, that's on a different topic. At the moment, for renal, there are 2 indications for whole genome sequence. That's cystic kidney disease and an unknown origin of end-stage renal disease of anyone under the age of 36 or 37, if I'm not mistaken. And the rest will be on panel. That's important to emphasize since you need to request your particular sample to the specific form, otherwise they wouldn't push through or they wouldn't be activated. So once the result is analyzed and ready to be returned, they will be sent back to their corresponding referee, which is me or the nephrologist. And if it's straightforward, meaning it's positive or pathogenic in line with the symptoms that the patient is experiencing, so that will be delivered to the patient. And of course, if it's quite complex in terms of incidental findings or uncertain significance, again, there would be an entity support that would involve the clinician, the CNS, as well as genetic counseling team, and of course, the genetic service or the genetic scientist to help interpret these results. And of course, cascade testing and family and fertility consultation is also in place if the patient would need further referrals. I will have included the resources needed for testing in this slide, and I think this will be circulated shortly after our webinar. Yeah. Next slide, please. So again, I've mentioned about the National Genomics Test Directory. I mean, it is updated annually. Actually, last year it was updated twice. So in orange, I've shared with you that there are 2 conditions that would pertain to whole genome sequence, and the rest will be gene panel. And you would see there the providers of which laboratory hub is responsible of in sequencing and analyzing these. Next slide. Again, this is just a screenshot of what the test directory looks like, and this is for cystic renal disease. It would include the testing criteria, and what's important is to take note of the R code, which is 193.4 for cystic renal, and the method that is needed. So I've encircled and emphasized this again because with my engagement with the clinicians and nurses who's trying to incorporate this with their clinics, most of the time they have a confusion of which form to use because it's separated on the websites available. And again, anything that is not WGS should be in the other form. The only difference is it does not include the consent for the National Genomics Research Library. Next slide. And of course, I would also like to share the importance of the panel app in which the test directory is dependent on. So we are only testing genes that are on the green, meaning we are in a traffic light system in which genes are categorized depending on their level of evidence in response to the or corresponding to the phenotype or the clinical manifestations and the gene. So at the moment, there is an ongoing or growing genes being included in the green category. Next slide. Again, this is just a brief overview of what you need for genetic testing. So the sample request form, which basically asks for a blood sample to be stored or tested, and it will go directly to your corresponding GLH. The record of discussion is basically a consent process. It involves the bulleted points needed for testing. And again, for whole genome sequence, it would include the National Genomics Research Library. And take note that it's not mandatory and can be, genetic testing can still proceed even without patient consenting to this. And we can discuss this on later appointments with them if they wish. And for equity, to prevent this, it is available in 11 different languages, and it can be done remotely with the changes made during the COVID pandemic, in which research and consenting have now moved to hybrid. Another important form needed to be used is the test order form, in which I have shared earlier, you need to take note of the R code needed and which form you would need to use. So it's either WGS or the non-WGS. And another important factor to take note is it would also include the human phenotype ontology. So it's basically a link and a short cheat sheet on the form that would mean you would need to indicate clinical manifestation that the patient has. So it's either renal or extrarenal. For example, multiple cysts is shown, hypertension, and so on. So you would at least need one to put in the TOF form for your test to be activated, but I would encourage to put as much as you could so that this would help the interpretation and analysis with the genetic scientists. Next slide. These will be the types of genetic test result that you would expect from a genetic report. I wouldn't go through all of them because we're a bit short of time, but the possible results would include either pathogenic or likely pathogenic, meaning there is a confirmed genetic diagnosis linked to the conditions and clinical manifestations that the patient has. So this will be reviewed by the MDT team as well as the genetic scientist before it is available. So it is similar to, as compared to incidental findings, genetic result is available. However, it's not related to what you're trying to request. For example, a patient may be investigated for a developmental delay. However, a cancer predisposition gene has been shown in the result, and this can be reviewed again by the corresponding MDT team. And that would also include, a possible misattributed parentage, in which is quite important to disclose during the record of discussion phase. For these two results, the treatment for the patient, either currently or for future management, may not be affected. However, insights about the prognosis and susceptibility to other conditions can be reviewed. And further referrals can also be made through the genetic counseling team in terms of cascade testing and so on. Again, there's a lot of ethical and legal social implications around this. That's why it's quite important to expand on this in terms and have a strong link with your genetic counseling team. Next would be no incidental findings, meaning there isn't any genetic diagnosis confirmed yet. However, it doesn't mean that, for example, the result may not be relevant now or there's nothing shown now. That's because, as I mentioned, the genes being tested are only in the green category. There are a few amber genes currently being updated and reviewed, and there could be a necessity for reclassification in terms of the genetics report being produced at this time. So again, we need to disclose to our patient that although there are no relevant or genetic conditions found, genetic genes linked to your particular condition, it can be reviewed again and they can be revisited for this. And that is similar to variant of uncertain significance, meaning at the moment there's not any sufficient evidence or information rather in terms of the reports that they have produced. However, again, this can be reviewed in the future. For the last two results, predictive testing cannot be offered to the patient and their family since there's little evidence of any genetic molecular diagnosis rather to be linked to their particular condition. However, we need to reassure to our patients that an ongoing renal management with them is still in place and would not be affected despite of. Next slide. This is just a quick screenshot of the renal WGS data that we have in Southeast. So over the past year, we have over 100% referrals and submissions of cases through the GLH, and we have tripled the reported cases, and we're constantly trying to improve on this in terms of capturing data, not just the whole genome sequence, since there are only 2 indications at the moment for the directory. As you can see in the orange, mainstreaming clinics such as ours is currently expanding and quite excited about that. And we're hoping to improve on this as well, not just regionally, but nationally, along with other alliances around the country. And on the right, you can see the heat map that we have. So it's quite concentrated in the central region. And we were quite happy to see that, areas such as in Sussex, as well as in the East, is also sprouting patients and being captured around that area. Next slide. Yep, of course, this wouldn't be possible without the collaborations that we have with the charities, ADPKD and nephrotic syndrome, as well as in Outport, as well as professional associations such as UK Kidney Association and AN UK, in terms of bringing awareness towards the genomic medicine, and of course, incorporating this in our daily practice. Next slide. And of course, I would also like to share the resources needed that people here who's working in either a clinician or a nurse who would like to learn more about genomic medicine. So Health Education England have established bite-sized genomics modules from 10 to 30 minutes, more of a taster of what it is, how it can be incorporated in our practice, such as genomic counseling, ethical, legal, and social implications, and so on. But of course, they're also funding postgraduates in terms of genomic medicine or genomic healthcare. So they will fund 4 modules per year, and you can upgrade to full masters as well. So please use the link below if you would like to learn more on that one. And of course, all of these are summarized in our corresponding alliances, not just in Southeast, but as well as in East. Next slide.
So that's the last one I've got on this slide,
Okay.
Ed.
Yeah.
Sorry, I was just using a different one to make sure I had all of your slides. I'll just stop sharing.
All right.
Great. So I think we'll hand over to Tess. So welcome, Tess. Thanks for joining us. I think you've got about 10 minutes, if that's okay.
Yeah, no problem. Thanks very much indeed, Katie. And thanks for that update, Eduardo. That was really interesting to see the progress that's been made and the number of referrals you've had. So yeah, I'm Tess. I'm Chief Executive of the Polycystic Kidney Disease Charity, and I am a patient with ADPKD. With actually a fast progressing truncating mutation in PKD1. And I'm sure many of you have encountered polycystic kidney disease patients. I don't have any slides, you'd be pleased to hear, but you're very welcome to ask me any questions, of course. So you'll have encountered patients with PKD in the course of their renal journey, particularly at kidney failure stage, where we represent 1 in 10 of the dialysis population and about 1 in 7 currently of kidney patients with a transplant, and that's because we on average will progress to kidney failure in mid-50s. However, it's also been known that not everybody progressed to kidney failure, but it is recognised. PKD is recognised as the most common inherited kidney disease worldwide, cited at about 1 in 1,000. So we're dotted around the outpatients department in general in the general CKD clinics, or even in my case, I was in hypertension clinic for quite some time, and sometimes pop up in urology as well. Historically, and certainly people like me were diagnosed with PKD, as we used to, and most people PKD will call it that. It's only recently patients will start calling it ADPKD. It's been pretty much known as PKD. And so people like me were diagnosed, being family screened, ultrasound, told they've got the cysts, and nothing can be done. We'll just check your bloods once a year, check your blood pressure, and see you next year. And if you were in a family that was known to have a history of fast progression, you'd obviously turn up in low clearance at a fairly early age, and then progress to kidney failure. So that was the traditional way of managing patients like us. More recently, with as was knowledge about the genes, it was known that there were at least 2 genes implicated: the PKD1 gene, the most common, and the PKD2. And then about 10 or 12 years ago, it was noted that in PKD1 there were again a split between a truncating and a non-truncating mutation. So you have a kind of gradation of severity, with PKD1 truncating mutations being the most common and the fastest progression, roughly accounting at the moment for about half of all patients with diagnosed PKD. And PKD2 was and PKD2 was about it was thought about 80%, 85% would have PKD1 and 15% would have PKD2. But there were always people who got genetically tested occasionally in research centres such as Cambridge or in Sheffield or Cardiff in the UK, who were clinically diagnosed for ultrasound with PKD and had cysts and were treated as PKD patients, but there was no genetic cause. And what we've of course discovered recently with whole genome is that we now have many more genes known to be causative of autosomal dominant PKD. So we now are starting in our community to have patients coming to us and saying, oh, I've just got PKD6 or PKD5. Not that anybody's calling them that, because that's not the intention, but what they have got in fact is an alteration in a GAMAB gene or a DNA JB11, or even an IFT140 or an AL6 or 8 or 9, and there are still about 7% of PKD cases that are unknown. So we expect a few more of these very rare PKD causing genes to be discovered. And what's also becoming apparent is that they are showing very different presentations. So the DNA JB11, for example, you'd be looking at probably a very mild progression of towards kidney failure, if at all, but they may well have polycystic liver disease, more severity. And So over time, the clinical management of patients will, we hope, change so that people perhaps with predisposition for polycystic liver disease will be identified earlier in clinics and be able to be have their polycystic liver disease managed more sooner and prompter than is currently the case. And at the same time, one could envisage where somebody has perhaps a gene alteration that's leads to a slower or perhaps never reach end stage, they might be handled differently in terms of frequency and on the pathway, although we're not there yet. Currently, everybody is treated the same. If you've got PKD, you've got PKD, and GFR rate of GFR decline and family history will be the guide. The other advantage of the gene testing, of course, will be that for families with a known fast progressing gene, particularly if it's a very early onset, and there are some very rare early onset cases, they can be offered fertility, family planning, counselling, and we know people are taking advantage of that. And secondly, there's interest from industry in looking at interventions that perhaps suit a particular genetic mutation type, and knowing who those patients are will enable them to be identified and offer the chance to take part in therapies which could help slow down the rate of progression of kidney failure. So it's a really exciting time for us. You know, it's not a condition that, despite it being the most commonly inherited kidney condition, it's never really been, we know, seen the inside of genetics clinics. I, in fact, had my blood tested through a back door at the Mayo Centre in the US. I sent my blood over to a research project and was told I had PKD1 truncating mutation, which fitted in with my family history. Although it's highly variable, there's 20 years difference between my older sister and me when we ended up at kidney failure. But pretty much followed a trajectory of PKD1 truncating. But it's still, you know, outside the specialist centres, we do know people who have never even offered genetic testing at all. So yeah, great times for us, and we're particularly excited that PKD has been sort of chosen by many of the alliances as a sort of paradigm because there are the numbers and you can show some benefits with it for the genomics embedding into the pathway. So I hope that wasn't too fast or too.
No, that was fantastic, yeah. Tess. Thank you.
I was so happy to answer any questions, and yeah.
Yeah, so I think it's a lot of information to condense into such a short lunch and learn session, but I think we can open up the session for Q&A. So if you've got any questions, feel free to pop your hand up or pop them in the chat, and yeah, we can do our best to help. Hi, Gerald.
Hello, thanks. I've just got a question for Eduardo, I think, if that's okay.
Absolutely.
We do send off a whole, usually cystic, disease, what is it, R193.4. And I never get any incidental results. Now, I spent a lot of time, in the consenting process talking about we may turn up something incidental, which may be of great significance. This is all part of whole genome sequencing, but nothing does turn up. Can I be assured that these significant incidental findings are being sort of screened for, because the information is there, and it just turns out that all the, I don't know, 5 to 10 that I've sent off so far just don't have anything incidental that needs to be talked about?
Yeah, I also have the same experience. Since we have started last year, I didn't have any incidental findings yet to be shared with our patients, although there are cases that the genetic scientists would be contacting the referee in regards to asking or investigating more on the clinical manifestations that the patient has. since they would like to link that to the genes that they're trying to look into. So we call this a deep phenotyping. So a genetic scientist would be emailing you in regards to other, renal or extra-renal clinical manifestations that they may have that you may have missed out in putting into the HPO terms found in the back of the TOF. So again, there would be a thorough review on their clinical notes of what other conditions that they may have. May it be investigating for aneurysm and so on, if you are requesting for PKD. So at the moment, in my experience, I only had one deep phenotyping investigation, and the genetic report still show a no finding. So no genes were found or linked to this particular patient. But then again, since we're looking at the whole genome sequence, they would still be asking, if needed, for anything that you would like to add in their HPO terms. Yeah.
Gemma, were you adding to that?
Yeah. So hi, I'm Gemma. I'm the education training lead for East Genomics. So just want to sort of clarify how whole genome sequencing and whole genome analysis is done. So while R193, it is a whole genome sequencing test, that means that yes, in the laboratory they sequence every base of the genome of the patient, but the analysis that is done is actually restricted to a panel of genes. So it is not the case that all genes are looked at. So from a clinical position, from a clinical standpoint, you shouldn't think of it as having a whole genome analysis for your patient. So you haven't seen incidental findings, but that, for example, it doesn't mean that your patient doesn't have hereditary breast and ovarian cancer syndrome, for example. It means that will not have been looked at. What is looked at is genes that are related to kidney disease. So a whole genome is sequenced but not analysed. It's just analysed for the genes that are related to the clinical indication for which you're testing. Now, so that's in order to minimise incidental findings. Incidental findings can always happen though with genetic testing. So we would expect them to be rare, which is why neither of you are seeing them or have experienced them. But it could happen due to, for a couple of reasons. It could be to do with the particular type of genetic change that occurs in a patient. For example, rather than a very small spelling mistake in the genome, it could be that a big chunk of a gene that affects kidney disease is deleted, and maybe another gene is deleted as well. And in that case, you might find that you've got a condition that affects more than one gene. So that would be an incidental finding. And Eduardo has also talked about, when we're testing, when we test parents alongside with patients, there is always the potential for misattributed paternity to be discovered. Other biological relationships can be discovered through genome sequencing that could trigger safeguarding returns in a hospital, for example. So these all very rare, but the way to think about it is not to think, when you're having a consent conversation with your patient, don't set an expectation of we're checking for everything in your genome. We're not. We're just trying to find a diagnosis for your kidney disease.
Can I just ask, is that the right thing to do? I mean, if I'm speaking with a youngish woman, or even any woman, and I can't remember the name, the breast cancer predisposition sort of gene comes up, maybe there's a family history and whatever, but let's say there isn't. I mean, I think patients, having discussed this, and obviously incorrectly as it turns out, I think patients, when I say to them, if we find that you've got a breast cancer gene, I'll say, we will sort of tell you. And I said, do you want to know? I mean, do you want to know the result? And they say, yeah, I mean, I'd much rather know than not. So I'm not sure about the ethics actually of ignoring the rest of the genome if we're just sort of, I mean, I'm sure this needs a big ethical conversation, but I totally misunderstood.
Yeah.
I mean, I thought that why we were making such a big thing about whole genome sequencing was exactly because of these incidental findings. And in my experience, most patients would want to know that they've got this breast cancer high risk gene.
So let me just clarify.
A little bit more discussion.
yeah, let me clarify a couple of terminologies there. So
Yeah.
when we think about incidental findings, which can happen with any genetic test, that is something that you stumble upon by mistake, that you can't help from seeing as part of the analysis. So rather like if you were taking an X-ray of a broken rib and you saw a mass in the lung, for example, that would be an incidental finding, something you couldn't help stumbling upon. When you're thinking about those other actionable findings that might be in someone's genome, like a predisposition to cancer or a predisposition to hereditary cardiomyopathy or something like that, that is called an additional finding or a secondary finding or a looked for finding. That is not currently being delivered in the NHS Genomic Medicine Service. It was explored in the 100,000 Genome Project. So the additional findings were part of the 100,000 Genome Project, and patients could choose to receive them or not. So it is being explored, and it's an ongoing conversation, and it may be something that, you know, happens later, but we're talking about that's a population screening protocol rather than a diagnostic test. So that is not happening currently, and it is part of wider ethical debate. There's loads and loads of literature and conversations about this in the sort of in the genomics field. But it's not happening. So that's so from your consent perspective, it's not what we're doing.
Okay, well, thank you for explaining that.
Thanks, Gemma. I've just got a hand from Ashika.
Yeah, just to so I'm in clinical genetics, guys, and I see all kinds of patients, not just renal patients, but lots of different patients for genetic conditions. And just to say that the reason that we have so many ethical debates around what we should be testing for and what we shouldn't be testing for is there are major implications. So when you sit somebody down and talk to them about renal conditions, you are covering quite a lot of that. Certainly Ed is covering a lot of that when he does the consenting. If you consent for things like BRCA in your clinic, there's so many implications that you haven't discussed. And actually, in our experience, some people will say no to testing after they've considered all of the different options. So it is really, really important that we consider all of them carefully before we offer genetic testing for everything. And I cannot state that enough. Having been a genetic counsellor for over a decade now, not everybody will choose to have genetic testing. The initial reaction might be, yes, test me for everything. But once they consider the options, I think a lot of them change their minds, which is why there's so much debate around it, just to say.
No, that's really helpful. Thank you, Ashika. I'm just conscious of time. I'm just going to pop another slide up on my screen. So I mentioned earlier around the project that is happening within East Genomics for cystic renal disease. We actually, oh, hold on. We actually have a number of workshops taking place at the moment, really focusing on identifying the nursing touch points within those genomic pathways and just the opportunity to enable equity of access and develop some supporting materials. They are open to registration. We've got one happening next week on the 20th of March. You are all more than welcome to come and join us. They've been really helpful workshops so far. We've learned a lot, so would really appreciate your input. What we'll do is, as well as sending around the slides from today, we'll also just send you an invitation to those workshops as well. And just to say thanks again for everybody for joining us today. Thank you ever so much to Ed and Tess for your input. We really appreciate it. Would really welcome any feedback from these sessions as well. I've popped the